Good morning and welcome to virtual medical grand rounds. Hopefully there are a bunch of people out there who are logged on, and we'd love to get feedback about how this works. So please send your evaluation forms after this, because that's the only way we'll know that you attended and were able to appreciate it. The CME part of it is also virtual, so if you submit that you attended the whole hour, we will get you 1 hour of CME credit. So this is how we plan to conduct grand rounds for the foreseeable future until this pandemic blows over. Limit to 20 in the audience, and please follow the 6-foot rule, no congregation. So without further ado, I'm going to introduce Naman Sharma, one of our residents, who will present the case.
Hello. Good morning, everyone, and thank you for being here, and thank you for other people who are listening to us. So I welcome you to the Medical Grand Rounds today. And today it's a resident case conference, and our topic is, the heading is, will the snowballs ever melt? And as we go through the case, we'll try to justify why we chose this topic. We present a 36-year-old African-American female who presented to the ED in April with complaints of cough and shortness of breath. Going to the history present list, her symptoms were progressing for the past 1 month. The cough was productive with mucus sputum production. She denied fever, chills, chest pain, or diaphoresis. Though she complained of some weight loss, but it was difficult to quantify how much she lost. She denies any travel, any pet, or insect contacts. Otherwise, she is relatively healthy, but had 2 recent urgent care visits in the past month for cough, where she was just symptomatically managed and never followed through with the PCP. Her past medical history of some asthma, some arthritis. She had some minor orthopedic procedure in the remote past. Family history was significant for hypertension in father, breast cancer in mother, renal cell cancer in maternal aunt, and again renal cell cancer and stomach cancer in maternal uncle. Social, she's a current smoker, smoking 1.5 packs a day for the past 15 years. She denies vaping, no drugs or alcohol. Her review of system was positive for fatigue, shortness of breath and cough, and wheezing. Vitals were hemodynamically stable, and she was saturating 98% on ambient air. Physical examination was essentially unremarkable except bilateral diffuse bronchi. Labs, essentially unremarkable, CBC, BMP, they also tested flu, which was negative. But the CT scan was surprisingly with diffuse bilateral opacities and small bilateral pleural effusion, which prompted us to get a CT scan, which showed multiple ground glass opacities, thickening of bilateral interlobular septum. There was an enlarged hilar mediastinal lymphnopathy, and there was a hilar mass on the left lower lobe. And there were multiple sclerotic lesions in the bones of the ribcage and the sternum. Given the acute presentation of the patient, the chest X-ray followed by CT scan, the top 2 differentials were either it's a very acute infectious process, multifocal pneumonia, versus something more serious like cancer. Though her chest X-ray and CT scan was very disturbing, but overall she was doing well. So she was admitted to the observation unit, treated with IV antibiotics for pneumonia, along with nebulizations and steroids. And she improved in few days, and she was discharged to follow up with pulmonology as outpatient in 4 to 6 weeks, repeat CT scan for resolution. But before she could see anybody in the community, within 3 weeks, she presented to Strong with similar symptoms of hypoxia and as acute weight loss. Now it was dramatic. She lost around 15 pounds in these 3 weeks. The repeat CT scan was unchanged for the hilar mass, with a narrowing of the left upper lobe bronchi and the post-obstructive pneumonia. It was concerning for post-obstructive pneumonia. There was also significant mediastinal lymph nodes and the sclerotic lesion of spine, sternum, ribs, bilateral pleural effusion, and also a hepatic mass. She was somehow managed symptomatically there and was discharged, but again readmitted to RGH with similar symptoms. This time, she underwent thoracocentesis, and a liter of exudative fluid was removed, which was positive for atypical cells. She also underwent a liver biopsy and was diagnosed as metastatic non-small cell lung cancer, adenocarcinoma. She was admitted this time and she was deteriorating. There was worsening of hypoxia. She was admitted to MICU, was on BiPAP. Since we had a tissue diagnosis, oncology was consulted, and the plan was, with the limited information, the plan was to start with first cycle of chemotherapy with carboplatin and pemetrexed. She improved, the hypoxia improved, and she was discharged to follow up as outpatient with oncology. The overall plan here was to continue till we get more information, to continue at least 4 cycles of chemotherapy and do a restaging scans to see how she responded. But before we could do that, she bounced back again with similar symptoms of progressive hypoxia. And every time when she came in, CT scan was done, PE was ruled out, but CT scan was concerning for progression of disease, lymphangitic spread. But this time she responded to steroids and antibiotics. Until this time, we were waiting for more information. And the PDL testing was done and was positive and for expression for 70%. We also did a Foundation 1 testing. It's a bunch of tests which test for various mutations so that we can target those mutations with specific agents. But it was unfortunately, the results were unavailable because the sample was too small. And the quadrant 360 testing was sent. It's basically also known as a liquid biopsy. In this, we basically send 2 tubes of blood, and they basically test the DNA of the tumor cells for various mutations. At this point, I'll ask Dr. Yi to come and discuss the slides of the pathology.
So I got the liver biopsy, and as you can see, this is a low power view. This is a low power view of the liver core biopsy. Basically shows sheets of tumor cell proliferation, and there's no hepatocyte you can see. And at a higher resolution, you can appreciate that the tumor cells make into a cytoplasmic vacuum, and the vacuum basically pushed the nucleus to the corner of the cell and form this like signal ring cell-like structure. Basically, this is just like adenocarcinoma with a signal ring cell features. And this kind of morphology can occur in breast cancer, lung cancer, in gastric cancer. So, so we went on to do immunostains, try to figure out the primary side of this tumor. And basically, here shows the immunophenotype of the tumor. The tumor cells are positive for CK7 and also positive for TTF1. And the TTF1 is a transcriptional factor specify a type 2 pneumocyte differentiation. It's more likely to be overexpressed in the lung primary adenocarcinoma. And we also did a bunch of other markers for breast. The GATA3 is specific for breast, and APAX8 for ovarian origin. And actually, we also did a CDX2 for a gastric origin. They are all negative. Basically, the immunoprofile pointed to the direction of a lung primary. And in the good old days, that would be signed out metastatic adenocarcinoma of lung origin. And in current days, we have to specify further classify based on their molecular profile. Here shows you the non-small cell lung adenocarcinoma. You can further divide it into adenocarcinoma. And there's some like squamous cell carcinoma. There's 11% that we just don't know what the cell's trying to be. And for the lung adenocarcinoma, the usual suspects such as KRAS mutation, EGFR mutation, and the interest for this grand rounds is the ALK translocation or ALK fusion. It's about 4% of lung adenocarcinoma will harbor this ALK translocation. And just a note that ALK translocation is also detected in the squamous cell carcinoma, especially for those young patients, non-smoker, And the most recent case report showed that a 73-year-old with squamous cell carcinoma, that patient is a non-smoker. And basically, the take-home message is that in some squamous cell carcinoma, rarely alkyl translocation can occur. And this is more for detection of alkyl translocation. In the old days, we use FISH, fluorescence in situ hybridization. And then we also have RT-PCR. Nowadays, we have next generation sequencing, and the next generation sequencing for cell-free DNA, basically the so-called liquid biopsy. And here's the diagram for the old FISH test. Basically, design two probes with a different fluorescence. And if in the wild type situation, the two signals should be close to each other. And when the translocation event occurred, these two signals will be apart physically, as shown here. That basically you show these two signals are away from each other. This is so-called break apart. For this patient, I think Dr. Patel decided to send the specimen for Foundation 1 sequencing. But somehow it's failed because they cannot get sufficient DNA for sequencing. And then we just found out that the case was sent for liquid biopsy. Basically, you send the plasma and for sequencing, and they found this EML4 alkyl fusion. Here is a paper published last year, and this is from Brigham woman. They have 16 cases of a patient with known translocation, either alkyl ROS1 or RET. And then they send the plasma to two different companies. One is Guardant 360, the other is CTDX Lung. And for the Guardant 360, they detected 7 out of 16. And the CTDX Lung got us 13 positive. And basically three cases were not detected by these two companies. And the take-home message for this finding is that, in case some, for patient like this, if the cell-free DNA sequencing is negative, it's not a bad idea to rebiopsy the patient and then do the Foundation 1 type of sequencing again. And then what is ALK protein? ALK is actually first discovered in anaplastic lymphoma, anaplastic large cell lymphoma back in 1994. And they found that this lymphoma has this protein kinase activity. Here is a protein, shows the protein kinase domain. And this translocation has occurred in other types of tumor, such as the inflammatory myofibroblast tumor, IMT. And it also occurred in renal cell carcinoma. Of course, it occurs in the non-small cell lung carcinoma. And ALK mutation or amplification has also been described in neuroblastoma. In the neuroblastoma, it's more point mutation or amplification. Point mutation has also been described in anaplastic thyroid carcinoma. And here it shows you that there's a portal called cbioportal.org. This is from Memorial Sloan Kettering. And they have this website. You can plug your favorite gene into the website, and you can see the mutation or translocation, whatever profile of this your favorite gene across the tumor types. And so there, Memorial Sloan Kettering has the impact sequencing is sort of like a Foundation 1 type of sequencing. They deposited about 10,000 cases in that database. So I basically just plugged the ALK gene in and to see the mutation amplification profile in various cancer type. As you can see that the green bar are the mutation, ALK mutations, and the red bar is the deletion, the purple is the translocation. So as you can see that this is about 4% is translocation has been detected in the non-small cell lung cancer, and in other cell types, and the translocation has been detected in renal cell carcinoma, salivary gland carcinoma, pancreatic cancer, soft tissue sarcoma, so on and so forth. And actually, there's a paper described 5 cases of ALK translocation in 5 pancreatic cancer patients. Those patients are young, less than 50 years old, and usually presented with metastatic disease. And the take-home message is that ALK fusion can occur in other types of carcinoma. So the ALK is so in our genome, we have like over 500 protein kinases, and ALK is belong to this big family, and it's very important in this in the cell survival and cell division. It activates many pathways. The major pathways activates is RAS, RAF, Merck, ERK pathway, and they can also activate the JAK-STAT pathway, basically keep the cells alive and promote cell division. And the structure has been solved a long time ago. I mean, I think it's pretty hairy to look at this thing. The major thing I think is that this protein is very interesting is that they all have a very conserved motif called P loop or glycine-rich loop. And this loop is used for coordinate the beta gamma phosphate of ATP or GTP. And it's very interesting. I guess evolution come upon with this conserved motif, and they took full advantage of it. And the glycine 12, glycine 13 of RAS basically is also in this loop. And based on this crystal structure, they can derive the catalytic mechanism, how the protein catalyze the transfer of the gamma phosphate from the ATP or GTP to a tyrosine residue, shown in this cartoon, that the P loop coordinated the beta gamma phosphate, and then there are all other catalytic domain come together and transfer the gamma phosphate to a tyrosine residue in the substrate peptide. And once you got this, you said, well, can I find some chemicals to block the activity of this enzyme to prevent this transfer from occurring? And over time, I think they have identified the many inhibitors for this type of kinases. And here shows this compound complex with this protein. As the gray, this is the molecule, this is a drug here. It's very close to that catalytic side, basically. And I think I'm going to stop here.
Thank you, Dr. Yi, for your expert opinion on this. Yeah, so coming back to our case. So now, as you know, that the PDL expression was 70%, and we are waiting for the quadrant 360 testing. Since we had some more information this time, so the cycle 2 Keytruda was added, which is a PDF1 ligand blocker, and it was added to the chemotherapy. But she was hospitalized again for similar symptoms. But the plan was to continue few cycles of Keytruda, at least 2, to see whether she's responding or not. So that's the reason we went for the cycle 3, we went with the same treatment of Keytruda with the chemotherapy. And she was hospitalized again. Now, with the CT scan showed worsening of disease. Now we were concerned that whether it's disease progression on the chemotherapy versus side effect of Keytruda, which can cause pneumonitis. And the patient was deteriorating day by day. And fortunately for us and for the patient, the quadrant 360 testing was positive for ALK gene rearrangement, which Dr. Yi talked about. And we requested for a drug called alectinib for approval by the insurance. But we had to continue the treatment. In the cycle 4, Keytruda was discontinued, and the plan was to go ahead with the chemotherapy. The patient was readmitted again with hypoxia. CT scan showed repeated disease progression. Now, the cycle 5, the patient was admitted at this time. And during the cycle 5 was the most difficult decision to make because all the patient progressed, or at least was not responding to the previous lines of therapy. We cannot use Keytruda because of the side effects, and alectinib was not approved yet. So the plan was to go, and we had to give something because the patient was actively crashing down. So the plan was to go ahead and give docetaxel or Taxotere while she was inpatient. But as anticipated, there was no improvement. But we got approval for alectinib in mid of September. I want you to just keep in mind on the dates that when the alectinib was started. This was started while the patient was inpatient. And she responded miraculously. In 3 weeks, in early October, her breathing improved remarkably, and she was off oxygen. After 12 weeks, there was further improvement in her symptoms of respiration, and there was no hospitalization. And she was being admitted every week. And now we have some drug-related side effect. After 12 weeks, she started developing myalgia, fluid retention, and she had gained around 50 pounds of weight in this 3 months, and which is considered a grade 3 toxicity, which prompted us to decrease the dose from 600 twice daily to 450 milligrams twice daily. And she further gained weight on this, and therefore we had to reduce the dose further to 300 milligrams twice daily. So the current status is the patient is still alive. We are talking about a patient probably who had few weeks to live. The way the disease was so aggressive. The last time she was hospitalized was in September 2018. We did a restaging every 3 months, and which shows remarkable disease improvement. The CT scan of the chest, abdomen, pelvis. The bone scans show stable disease. The liver mets have improved, and they are no longer visible. And the patient is currently off oxygen. She's independently living. Weight is stable, and she's working part-time 20 hours per week. And I'll request Dr. Haren to go with the CT scans so that we can see things melt.
Okay, let's start this from the beginning. So I think the title of the grand rounds today is very appropriate, not only because it's spring and I'm waiting for the snowballs to really melt, but also because of the findings you're going to see on the CAT scan, which are pretty remarkable. So this is the initial scan, and she had several scans, so I just selected some that were I thought showed disease and marked improvement the best. So this is May 2018, and we're looking at a couple cuts here on mediastinal windows. And the tumor is all of this soft tissue density that's in here in a region called the aorticopulmonary window, which is, just to give you an idea, this is the aortic arch, so we're just below it. And we have tumor here that's sort of extending along the bronchovascular bundle. It's actually extending into the left upper lobe. So this is all tumor. All this soft tissue density shouldn't be here. Okay, and this nodule here, and we have a right pleural effusion. This is a cut that's a little bit lower, and this is showing the tumor extending into the lingular segment of the left upper lobe. So we're down a little bit lower here, and you can see all of this soft tissue density that, again, shouldn't be here. This is all tumor. There's that right pleural effusion again. These are lung windows, so we've just changed the windowing a little bit so you actually see the lung parenchyma. And that's that tumor you were seeing in the lingula. So that's here sort of extending inferiorly again. And then we start to see a little bit of nodularity and a little bit of ground glass opacity that we saw in the initial chest x-ray that was shown. And that is all tumor. This is what lymphangitic carcinomatosis looks like. So this is all what's called interlobular septal thickening. So all of these extra lines that are here, these longer lines, all of this is interlobular septal thickening. There's a broad differential. So when you see curly B lines on a chest x-ray and everyone says pulmonary edema, there's actually differentials. So you're probably right most of the time. That's very common that we see that with pulmonary edema. But one of the differentials is lymphangitic carcinomatosis, and that's what this is. How do you tell the difference? It can be very difficult. We actually look for nodularity, and I don't know how well this projects, but there's a little bit of nodularity along the areas of interlobular septal thickening and along the fissures. So this is all lymphangitic carcinomatosis extending from the lung apices inferiorly into the middle lobe and both lower lobes. These are bone windows, so we change up the windowing a little bit again, and I wanted to show you the bone mets here. So unfortunately, she had diffuse bone metastases. All of these little sclerotic lesions that you see in the spine and the sternum in the ribs. That's all metastatic disease. So that's her initial presentation. This is a sagittal view, just showing the bone metastases again. So unfortunately, all of these little sclerotic lesions that are in the spine and in the sternum, that's all bone metastases. And as alluded to initially a presentation, this is a cut from the upper abdomen. So we're looking at the liver here, and this is a metastatic lesion within the liver. She had a couple other tiny low attenuation lesions that were too small to characterize, but probably were little metastases. It's hard to really know. And there's that pleural effusion again. This is August, so this is 3 months later or so. And unfortunately, disease progression here, as was alluded to in the talk. So if you remember from the initial slides, there wasn't this much soft tissue density in the aortic pulmonary window region, and now we're seeing tumor, unfortunately, in both lungs diffusely. So this is all tumor in the right lung here, tumor in the left lung that's extending down into that lingular segment again. This is soft tissue density window and lung window, showing the same thing. So again, we have some patchy ill-defined alveolar disease that wasn't there before. There's a differential for that, but it was suggestive of diffuse tumor. And then we have the tumor extending down into the lingula. This is another cut, just a little bit lower, showing that alveolar disease and the ground glass opacity, and then lymphangitic carcinomatosis again, which is progressing. We're seeing more interlobular septal thickening. It's becoming more nodular, so all that septal thickening, these little beaded nodular appearance of the septal thickening is all that lymphangitic carcinomatosis. So unfortunately, progression in August. This is a cut a little bit lower. Again, showing lymphangitic carcinomatosis that's progressing. And here's the bone mets again. The bone mets were relatively stable, actually, but the rest of the disease showed pretty significant progression. Again, the sagittal view of the spine showing all of the diffuse bone mets. And then here, axial view, again, showing bone metastases. Again, that's August. Here's that liver lesion now, and unfortunately, this is August versus May. So if you remember, in May, the liver lesion was this size, and I don't know how well it projects, but it's actually getting larger, unfortunately. So her metastatic lesion is getting larger. She has a new metastatic lesion here, so things are not going in the right direction as of August. But in December, this is when the snowballs start to melt. Okay, so this is actually incredibly impressive. So in December, if you remember from the initial slide, we had a fair amount of soft tissue density in the aortopulmonary window region. That's getting much better. So you have a little bit of soft tissue density here. There's still some residual tumor, but it's significantly better. And if you remember, as we went down inferiorly along that left upper lobe bronchus, there was tumor here, and that's all gone now. Okay, so here's the soft tissue density and lung windows showing that that tumor now used to occupy the entirety of the lingula. That's almost completely gone. And we go down more inferiorly, a little bit of nodularity there. But remember how that right lung looked before. That's markedly improved. Here are a couple other cuts from the lung windows. Remember that lymphangitic carcinomatosis? You don't even really see it now. I mean, there's a little bit of septal thickening, okay, but that's markedly improved, if not resolved. We go down a little bit lower. Again, marked improvement. Remember how that right lung base looked? Significantly improved on both sides. The bone mets, again, were pretty stable. Just showing some metastases again in the spine and the sternum. They were relatively stable throughout the course. Here that is again on the sagittal view. Here's the liver lesion. The windowing here is a little bit different, so it doesn't show up as well, but it actually is starting to decrease in size. You can still see it there, but it's getting a bit smaller at this point in December. And then February, is like summer has happened. So, there's really no residual tumor anymore. I mean, there's a little bit of soft tissue density in the aorticopulmonary window region here, just a minimal amount, which probably at this point is just scarring. It's probably not even active tumor. Go down a little bit, completely gone. Looks complete. This is a normal cut from a chest CT at this point. So February versus August, right? I mean, look at the difference. So this is February and this is August, right? So you can see how marked improvement in that tumor bilaterally, where it really is basically back to normal. Here's February. Okay, again, really no lymphangitic carcinomatosis here. I mean, it's really resolved. You go down, there might be a couple of areas of septal thickening, but again, basically resolution. And if you compare this to the August scan, look at the difference, right? So this is what we were looking at when it was at its worst. And a lot of septal thickening, a lot of nodularity, completely clean. This is just a normal CT at this point. And again, here we are at the bases, right? So you remember what the base looked like in August 2018. Marked disease here at the bases bilaterally before. Septal thickening, nodularity, look at it now. little bit of septal thickening, probably just scarring at this point, but basically complete resolution from a radiologic standpoint. So pretty impressive. The bone mets, pretty stable. There's some areas that might look actually even a little bit improved, a little bit difficult call, but basically normal, or stable in terms of the bone mets, but normal in terms of the rest of the chest CT. This is the liver lesion, right? So this is the liver lesion when it was at its worst. You don't even really see a lesion anymore. There's a little spot there, which is probably a little bit of residual tumor or scarring, but that's basically resolved. And that other lesion that was there, gone. So the snowballs have definitely melted. So pretty impressive.
Thank you so much. So I'd like to thank Naman for coming up with this appropriate title. I was struggling whether we should name this title Hit the Right Target, but Snowballs Melting is the appropriate title. And thank you, Dr. Yee and Dr. O'Hannon, for helping us out. So I'm going to talk about the ALK and PD-L1 positive non-small cell lung cancer. So let's get a brief overview. So lung cancer, we divide into non-small cell lung cancer and small cell lung cancer. Almost 85% of the lung cancer diagnosed are non-small cell lung cancer, the majority of which are adenocarcinoma, followed by squamous cell carcinoma, followed by non-specified or mixed tumor and large cell carcinoma. So prior to 2005, the management of lung cancer was one size fits all. Everybody got platinum-based doublet, and the average survival was around 9 months or so. Between 2005 and 2010, the approach changed. The treatment became more specific based on the underlying histology. So squamous and non-squamous mattered. Maintenance therapy became standard of care. And around 2010 is when the era of precision medicine started. And EGFR and ALK, these were the first two targets in non-small cell lung cancer that led the way. Initial approval was for EGFR TKI, followed by ALK TKI. And following the EGFR and ALK, many more genes have been now diagnosed, although with lower frequency, and we have specific targets towards each gene. So today, a first-line treatment option for stage 4 non-small cell lung cancer is more precise. It's based on the expression of PD-L1. It's based on the genomic alteration noted in the 4 main genes, the EGFR, ALK, ROS1, and BRAF. And there are other several genes we also look at, like the NTRK, MET, RET, and ERBB2, but not as a first-line option. So our patient had PD-L1 expression of greater than 50%, which was 70. So Keytruda or pembrolizumab alone, single agent, or in combination with chemotherapy would have been the right choice. And at that time when we saw the patient's condition was declining pretty quickly. She was in the hospital, she was hypoxic. We did not have time to wait for the genomic studies to come back. We needed to act right away, which we did with the first cycle of treatment. And when we did the first cycle of treatment, we did not even have the PD-L1 expression data, so the patient got histology-based or histology-specific platinum doublet with combination of platinum agent and pemetrexed or Alimta, which is the standard of care. Now, immune checkpoint inhibitors has changed dramatically the oncology arena, and now we have revolutionized the way we treat cancer by blocking the various checkpoints, the PD-1, PD-L1, and the CTLA-4. There are various inhibitors of PD-1 and PD-L1 approved already and in clinical use for the last 5 years or so. They are FDA approved in various malignancies. Initially it was the melanoma and the renal cell carcinoma, followed by all these other cancers, and widely used in non-small cell lung cancer. So since our patient got pembrolizumab and Keytruda, I'm going to focus on Keytruda. It's FDA approved both as a single agent or monotherapy or in combination with platinum-based doublet for management of non-small cell lung cancer in the first-line setting. The regimen that our patient got was based on the Keynote 189 trial that was published in the NEJM in May 2018. And in this trial, patients were treated with platinum-based doublet with or without Keytruda. And this trial did not enroll patients with EGFR and ALK genomic alteration. So that's a key point here. Even in the monotherapy arm, they excluded patients who had EGFR or ALK genomic aberrations. Keytruda is also approved in the second-line setting based on the Keynote 10 trial, and it was compared as monotherapy versus the standard of care second-line treatment. And once again, patients with if the patient had EGFR and ALK genomic aberration, they should have had disease progression on FDA-approved therapy targeting that target specifically. But we found out through this treatment, once we got the PD-L1 expression data of 70%, we rightfully added pembrolizumab to the platinum-based doublet therapy, hoping that she would have a good response and get out of this hypoxic issue, which was threatening her life. And unfortunately, the Foundation 1 testing was negative, and we had to wait for the Garden testing to come. And in the meanwhile, she got a couple of cycles with the combination chemoimmunotherapy arm, but she did not improve. In fact, she started getting worse, and we still had to give her some kind of treatment in the inpatient setting. So we changed this to Taxotere or docetaxel, and I think she was in the ICU when we gave that. And at the same time, we got information that the ALK gene rearrangement was positive. So in patients who have ALK gene rearrangement positive, various tyrosine kinase inhibitors are approved. And I want to talk about, very briefly, Dr. Yi stressed upon this pathway. The EML4 ALK fusion protein activates PI3 kinase AKT-mTOR S6K pathway, which promotes cell survival, and the RAS-MEK-ERK pathway, which promotes cell division or cell proliferation. And if we can target this fusion protein using crizotinib, we can help patients with ALK-positive non-small cell lung cancer. So crizotinib, I want to spend just a few slides on it because the approval of crizotinib was very historic. Crizotinib received accelerated FDA approval in 2011 based on 2 single-arm studies revealing response rate of 50 to 60% and median duration of response of 42 to 48 weeks. There was no randomized phase 3 trial, there was no survival data, but the accelerated approval was given. Why? Historically, with platinum-based doublets, the response rate is 20% in the first-line setting. Here it was 50 to 60%. The average survival used to be 9 months. Duration of response is almost 10 months with this drug, and this is why this drug got accelerated approval even without the phase 3 data. The phase 3 trial was conducted. This was the Profile 1014 trial, which was published in NEJM in December 2014, where patients who had ALK-positive, non-squamous, non-small cell lung cancer who had not received any prior treatment were randomized to receive crizotinib versus the standard of care platinum-based doublet. The primary endpoint was progression-free survival, which was statistically significant in favor of crizotinib, 10.9 months versus 7 months. And the overall response rate was 74% versus 45%. The hazard ratio was not significant for death, and the 1-year survival difference was just 5%, but crossover to crizotinib was allowed after patients progressed on chemotherapy, which could have played a role in the survival data. Crizotinib was associated with reduction in lung cancer symptoms and improvement in quality of life as compared to chemotherapy. You saw our patient, lung cancer symptoms improved, her quality of life improved, she's back to work, she's working part-time, and she's living her life as normally as she can. The common side effects noted with crizotinib, and the unique one was the vision disorders like floaters, visual impairment, some photophobia or diplopia, and some GI symptoms and edema. The most common grade 3 or 4 side effects were increase in ALT and neutropenia. Life-threatening or fatal treatment-related pneumonitis was reported, but less than 2%. So today we have at least 5 agents targeting the ALK gene rearrangement, which have been approved over the last 10 years. Alectinib was compared against crizotinib, which was then the standard of care in the ALEX trial, which was published in the NEJM in 2017. And this, again, randomized patients who had metastatic, untreated, ALK-positive, non-small cell lung cancer in 1-to-1 fashion to receive alectinib or crizotinib. The primary endpoint was progression-free survival, and the secondary endpoint was independent review committee assessed progression-free survival, overall response rate, time to CNS progression, and overall survival. Median follow-up was 18 months. The overall response rate was 83% in this subgroup versus 75% on crizotinib. 1-year event-free survival was 68% versus 49% and statistically significant. Median progression survival after median follow-up of 18 months was not reached in alectinib and was 11 months with crizotinib. And this is why alectinib was chosen over crizotinib in our patients. The most common side effects that occurred in descending order of occurrence were anemia, peripheral edema, myalgia, high bilirubin, high AST/ALT, nausea, diarrhea, weight gain in around 10% of the patient, vomiting, musculoskeletal pain, and photosensitivity. Our patient gained 50 pounds in 3 months, and that is the grade 3 toxicity from the drug itself. She also cannot work for more than 6 hours a day because she has myalgia and musculoskeletal pain, so she is working part-time because of the same. And after dose reduction, her weight stabilized, but she was not gaining weight as fast, and when we cut it down to 50%, her weight has stabilized. Now with diet and lifestyle modifications, she started to lose weight. She does not have any respiratory symptoms at all. So the side effect profile is manageable now, and she's on alectinib 300 milligram twice a day at this point. So what I wanted to highlight with this case conference was the role of anti-PD-1 agent in first-line setting, the role of ALK inhibitors, but also what's the role of immune checkpoint inhibitors in ALK-positive patients? We know from our experience with EGFR-mutated patients that these patients may not have such a striking response to immune checkpoint inhibitors, or even worse response. And why may that be the case? So there was this trial called the Checkmate 370 trial published in Journal of Thoracic Oncology in May 2018, wherein they had 5 cohorts. This was a phase 1 and 2 study, and the 5th cohort evaluated combination of nivolumab or Opdivo and crizotinib. So combination of anti-PD-1 therapy and anti-ALK therapy in the first-line setting in patients with recurrent, locally advanced metastatic ALK-positive non-small cell lung cancer, and their primary objective was to assess safety and tolerability. Interim analysis was planned, and if more than 20% toxicity was noted, that study should be discontinued, and that's what they did because they found 5 patients out of 13 that were in this cohort who developed grade 3 to grade 5 hepatotoxicity. 2 patients died with this combination. The overall response rate was 61%. Now, if you look at the single agent response rate of crizotinib and alectinib alone, 75% and 83%. So the combination, the overall response rate was less, and toxicities were high, leading to death. So this study was discontinued, and patients who were already on and doing well on this study as well, they were asked to discontinue the treatment. So what do we do when we have patients with ALK gene rearrangement and PD-L1 expression? Which is the right target? We have 2 targets. So as I have shown you that maybe PD-1 is not the right target in patients who have ALK gene rearrangement or EGFR mutation for that matter. And why would that be so? So for immunotherapy to work, we need to understand the concept of how this works. Cancer is formed when a cell undergoes somatic mutation and expresses neoantigen on the cell surface. Some of the neoantigens can be immunogenic and mount an immune response where lymphocytes will infiltrate the tumor. Some are not. The more immunogenic the tumor is, the higher the tumor mutation burden, the higher the tumor infiltrating lymphocytes in the tumor. To evade the immune mechanism, the tumor itself will start expressing PD-L1 protein on its cell surface and shut off the immune system. If that is the primary mechanism of immune evasion of the tumor, yes, the anti-PD-1 therapy will work because you are decoupling the PD-L1 from the PD-1 pathway. But does the same microenvironment occur in patients who have EGFR mutation or ALK positive? So no, we don't have a clear explanation of why this happens, but the hypothesis is the PDL expression in ALK positive non-small cell lung cancer versus all the genomic alteration negative non-small cell lung cancer is different. So when you have no genomic alteration, the PD-L1 expression is in response to tumor infiltrating lymphocytes trying to attack the tumor. But in patients who have EGFR mutation or ALK gene rearrangement, the expression of PD-L1 is probably driven by the oncogenic signaling pathway. Nobody knows how, but it's probably not related to the immune mechanism. And if that's not the case, probably immune therapy may not work in some of these patients. If it's not immunogenic, then tumor infiltrating lymphocytes are either absent in this kind of tumors, so you cannot use the efficacy of anti-PD-1 agent, or if tumor lymphocytes are present, we also know now that not all tumor infiltrating lymphocytes are specific to the tumor antigen. Some of them can be just bystanders. And with flow cytometry, they have found that there are CD39 negative, CD8 positive T cells who are considered bystanders. So, lab studies have shown that. So that's the second thing. And the third thing is patients who have these mutations. We were so ingrained early on, or 10 years ago, who should we test for EGFR mutation and ALK mutation? A young patient, a female patient of Asian origin with non-smoking history and having adenocarcinoma. Why do you think we saw those patients? Those patients had less antigenic stimulation and less somatic hypermutation, low tumor burden, and the tumor was not driven through the immune mechanism. And probably that's why the frequency of presence of EGFR mutation and ALK gene rearrangement was high in those patients. Today, we test all non-squamous, non-small cell lung cancer patient and very young patient or any patient with a non-smoking history and squamous cell carcinoma, you should test for all these mutations because they are more likely to harbor these genomic alterations. So that's my hypothesis, and maybe it's the tumor microenvironment and the low tumor mutation burden is why immune checkpoint inhibitors don't really work well in ALK-positive non-small cell lung cancer patients. So when we are managing non-small cell lung cancer patient, hitting the right target matters, and only then the snowballs will melt away. Thank you for your attention, and I'll take questions. I need to understand the question, though.
Your hypothesis is tumor microenvironment.
Right.
Maybe mutation as to how the immune system.
Right. Right.
So you'll be able to use your targeted therapy more efficient, right?
Right.
Is there any way you can test?
Yeah. So the question is there any way we can test the tumor microenvironment and for tumor mutation burden to predict response to immune therapy? And the answer is yes, but it's not as prevalent or easy to test in every single lab. So we need to do we need to quantify tumor infiltrating lymphocytes. How much is high, how much is low? We don't know that yet. We can definitely find CD39 negative, CD8 positive T cells, which would be considered bystanders. And we also check for tumor mutation burden. Tumor mutation burden of more than 10 was considered significant, but it has not got into fashion. So it's still early on. We're still trying to figure out how we can target this. So I did not want to complicate this presentation, but based on the tumor infiltrating lymphocytes and PD-L1 expression, there are 4 different types of tumor microenvironment. Type 1 is PD-L1 positive and tumor infiltrating lymphocyte positive. Type 2 is both are negative. Type 3 is PD-1 positive and tumor infiltrating lymphocytes negative. And type 4 is PD-1 negative and tumor infiltrating lymphocytes positive. And so the type 1 is where you have both positive. That's where the immune system, just this monotherapy anti-PD-1 treatment would work. In type 2, both are negative. So we use a combination of Opdivo and ipilimumab in melanoma. The idea is to, with the ipilimumab, recruit more T cells going into the tumor. When the T cells go into the tumor, they will force the expression of PD-L1, and with using the Opdivo, you can target that. But type 3 and type 4, we are still not there yet. So this is still in the works of, can we further stratify PD-L1 tumors based on the tumor microenvironment? So good question. Hi, Ron. I don't know that. Insurance, we were able to cover from insurance, and the company is good enough to help us with funding as well.
Really fascinating how treatment now go hand in hand with molecular biology. And I'm curious if there are any parallels with molecular biology and other clinical things. I don't know as much about lung cancer, but leukemia, you have certain molecular changes, and the subtype of leukemia goes hand in hand with that gene repair. Are there certain things about ALK-positive lung cancer histologically is different, or clinically is different in terms of the way it's made, other than some of the epidemiology?
Not as clearly defined as our leukemia patients, where some, we can identify an underlying genomic alteration. But these patients with genomic alterations are young. They have limited or no history of smoking, and I don't know if that you would present necessarily present with dramatic disease, but usually because they probably are presenting more with advanced disease, but not defined. So no, there is no a prototypical patient which is EGFR mutated will present this way, ALK will present this way, or ROS will present this way. There is no typical presentation for that.
Do they tend to be squamous versus adeno versus?
They tend to be more of adenocarcinoma. So squamous cell carcinoma is more in patients who have a smoking history. So if you have a squamous cell carcinoma patient with no smoking history, you have to think of these mutations first, because it's very atypical for a non-smoker to have squamous cell carcinoma. Yes?
The initial presentation was in May, and the targeted patient, appropriate targeted treatment was only started in September.
Correct.
So that's 4 months.
Right.
Do you think, was there a delay?
No, we had no choice. So when we saw her in May, or when she was hospitalized, she was crashing. We could not have waited for 2-3 weeks to do the testing and then wait for another 2-3 weeks to get the drug. She would have died. So we had to do what we had to do with the chemotherapy, and then we had to send the foundation one testing. If the foundation one testing had resulted, she probably would not have got 4, 5, or 5 cycles of chemotherapy, because we would have had the results earlier. But because foundation itself takes 2 to 3 weeks to get back, so we could not. We had no time to wait. She was crashing.
My question, I mean, our team was involved maybe later, initially she had was admitted as the patient and treated for pneumonia and shock.
Right. So you have to remember, this is the 36-year-old patient coming with shortness of breath and signs and symptoms of multifocal pneumonia. You don't think of cancer first, do you? You treat as pneumonia. So I don't think anything was, again, missed in this patient, but the patient was having recurrent symptoms and very striking presentation. So this bears in mind, if the patient is not getting better and if they keep coming in again and again with respiratory symptoms, think of cancer. Young patients get cancer. So don't just have a bias of, this patient is young, this cancer is not a likely diagnosis. It is a possible diagnosis. Yes, Jyoti.
Do you think that in a patient in whom the overwhelming thing is the ALK mutation, and these are the cases that we first about the ALK, do you think there was probably maybe that she actually progressed faster or it declined faster because we used?
So this is all speculation, right? She was crashing even before we started treatment. Then we gave her Alimta-based treatment. One of the side effects of Alimta is pneumonitis, right? So after first cycle, she's still in the hospital. Is it progression of disease because the treatment just started? Is it a side effect of alectinib? We don't know. And while we don't have any other agent, what are we going to do? Give the best treatment. So we gave her the pembrolizumab, right? Again, 2 cycles and she's still in the hospital. So I had to think, is it pembrolizumab-induced pneumonitis? It is the disease progression? Is it the Alimta toxicity? This was a very difficult case to manage, and it was very difficult for us to make a decision. Am I giving her a treatment that's not working, or am I giving her a treatment that's giving her side effects? Hyperprogression has been reported in patients who get immunotherapy. 10 to 15% of the patients who get immunotherapy have hyperprogression. And they also progress very rapidly too. So is that hyperprogression, or it was just that her cancer was resistant to chemoimmunotherapy? All speculations. I've been thinking about all that, saying, what did we do? But we had no choice at that time.
In this patient, the dose of the drug was reduced to almost half.
Right.
I was wondering if that has an effect on the therapeutic.
It has not. She's had a complete response, and she's been on 300 twice a day for, I think, more than 6 months now. So no. And so typically we will dose reduce to 50%, and beyond 50% we won't dose reduce. In oncology, we'll discontinue the drug or switch to a different drug. But she was tolerating the drug so well and it was working so well, I tried to bring the dose down as much as possible so that the weight stabilized, which it did. So she's very stable now. She's very happy. She's going on with her life, working part-time. It is just magical. To what I saw in summer of 2018 versus now, this patient could have died in 2018, and she's working and she's living her life normally right now.
So just a comment, I think this information that these mutations are more common in non-smokers is very interesting, because cancer seems to be a disease for the most part that occurs with random mutations in tissues that are dividing more. So if your cells are dividing more, they're more likely to mutate and more likely to get cancer. So if you plot the rate of division of a tissue against the rate of getting cancer, it correlates very well. Some of the exceptions are things like smokers. So perhaps if you have a carcinogen that's causing the cancer, the mechanism of development of that cancer is different, and therefore you're not going to have these random ALK mutations.
Right.
Whereas the the random mutation that just happens in dividing tissue is more likely to be this. So mechanistically, you wonder if that's the case.
Yeah, you wonder. And again, she was a smoker, right? 1.5 pack per day for 15 years. So she has a good 20 plus pack year smoking history. Less likely to have the mutation, right? So more likely we should have given her the chemotherapy because my pretest probability for her having a mutation was really low. So this, again, the learning point is smokers can have mutations too, although less, and she was lucky to have it.
Smokers get random mutations too.
Right. So again, the bias should not be, so age should not be a bias, and smoking history should not be a bias. A young patient, regardless of smoking history, we should test for mutations. Thank you so much.